All right, let's jump right in, shall we? Today, we're diving into something that's super relevant for anyone working in healthcare, especially in those busy EDs or if you're going through residency. We're tackling bipolar disorder.
Yeah, and to really get into the clinical nitty-gritty, we'll be drawing insights from a 2024 article. It's called Bipolar Disorders in the Emergency Department.
Okay, got it. So, bipolar disorders in the emergency department. Who are the authors on that one again?
It's by Carmen Wolf and Nicole McCoyne. It was published in the Emergency Medicine Clinics of North America. Really great resource for this topic.
Emergency Medicine Clinics of North America. I'll have to check that out. Okay, so before we get lost in all the clinical details, let's just take a moment to really grasp the seriousness of this condition.
Yeah, absolutely.
I mean, we're talking about people with bipolar disorder having a life expectancy that's, get this, 13.6 years shorter for men.
Wow.
And 12.1 years shorter for women compared to everyone else. That's a huge difference.
It really is. And it underscores why understanding and managing bipolar disorder effectively is absolutely crucial.
Absolutely. And it's not just about mental health either.
Right, you're hitting on a key point there. This decreased life expectancy is largely driven by a higher risk of cardiovascular disease. So we need to be thinking about the whole picture, the physical health implications as well.
It's all connected. So when we say bipolar disorder, what exactly are we talking about here? Can you just walk us through the basics using like that DSM-5 criteria, just to make sure we're all on the same page?
Sure. So the DSM-5 lays it out pretty clearly. For bipolar 1, the defining characteristic is having at least one manic episode. And get this, it doesn't even require other episodes like hypomania, depression, or even psychosis. Just that one manic episode is enough.
Okay, interesting. So one manic episode and boom, that's bipolar 1. What about bipolar 2 then?
Bipolar 2, you need both a hypomanic episode and a major depressive episode. But importantly, no full-blown manic episodes. That's the key difference.
Got it. So bipolar 1, at least one manic episode.
Yeah.
Bipolar 2, hypomania and major depression, but no mania.
Yeah.
But, in the real world, it's probably not always so black and white, right? How often do those textbook presentations actually show up in the ED?
You're absolutely right. It's not always textbook. We often see patients presenting with a blend of symptoms, mania, depression, psychosis, all mixed up.
Right. So it's like a puzzle with some of the pieces missing.
Exactly.
And speaking of tricky presentations, I found this observation about bipolar 2 in the article really fascinating.
Oh, yeah.
Yeah. Wolf and McCoyne suggest that patients with bipolar 2 might actually report more, like prominent depressive symptoms. And they might function better overall than those with bipolar 1. Doesn't that seem a little counterintuitive?
It does at first glance, right. But if you consider the impact of a full-blown manic episode, those manic episodes in bipolar, I can be so disruptive that they lead to significant consequences and just overall functional impairment.
Okay, yeah, I'm with you.
While with bipolar 2, those hypomanic episodes might not even be recognized, and so the focus shifts to the more prominent depressive symptoms.
Okay, that actually makes a lot of sense when you put it that way. So let's say we have a patient in the ED, and we suspect they might have bipolar disorder. What's our next step?
Medical clearance. That's absolutely crucial. We need to rule out any underlying medical conditions that could be contributing to their psychiatric symptoms.
So it's not just about addressing their mental state right then and there.
Nope. We need to take a step back and make sure we're not missing something else entirely.
What kind of tests are we talking about for that medical clearance?
We start with the basics: a complete blood count, a CBC, and a basic metabolic panel, the BMP.
Okay, CBC and BMP. Got it. What exactly are we looking for with those?
With the CBC, we're checking for things like a granulocytosis, that can be a side effect of carbamazepine, and then thrombocytopenia, which we sometimes see with Dival-Pro-X. And with the BMP, we're looking at electrolytes, Hypernatremia can be a sign of lithium-induced nephrogenic diabetes insipidus.
Whoa, hold on a sec. You're throwing out some pretty heavy medical jargon there. For those of us who haven't quite mastered nephrology yet, can you break that down a bit?
Of course. Basically, nephrogenic diabetes insipidus is when the kidneys they can't concentrate urine properly, and this can lead to excessive urination and dehydration. And lithium, which is a common medication for bipolar disorder, can sometimes cause this as a side effect. So by checking those sodium levels, we can get a clue that something might be off.
Okay, that clears things up a bit. So we're checking blood counts, looking for electrolyte imbalances, anything else we need to be really careful about when it comes to medical clearance for these patients.
We can't forget about lithium toxicity. Lithium has a narrow therapeutic window, meaning the difference between an effective dose and a toxic dose is pretty small. Recognizing those signs of lithium toxicity, that's crucial in the ED.
Can you give us a rundown of what those signs might look like, based on the severity?
Sure. So mild toxicity, you might see things like lack of concentration, lethargy, or slurred speech. As it gets more moderate, you start seeing confusion, maybe an unsteady gait. But if those lithium levels climb above 2.5 millimole, now we're talking severe toxicity. You can see delirium, coma, extrapyramidal symptoms, even seizures. And these patients might even need hemodialysis.
Okay, wow, that sounds really serious. So we've got medical clearance down, but let's be real, the ED is all about speed, right? We need to stabilize those acute symptoms fast. What are our go-to treatment options?
Right, so the focus in the ED is on acute management. For acute mania, you might consider mood stabilizers like carbamazepine and divalproex. But research actually suggests that antipsychotics like haloperidol, risperidone, or olanzapine may be more effective in those acute settings.
So we're leaning towards antipsychotics in a lot of cases. Interesting. What about for acute depression? Would we try antidepressants?
That's where things get a little tricky. Antidepressants, well, they can sometimes trigger mood destabilization, especially in bipolar I. So it's not as simple as just giving them an SSRI and calling it a day.
Right. No quick fixes with antidepressants. What about long-term treatment? Do we try to figure that out in the ED too?
Not really. The truth is there's limited high-quality evidence to guide those long-term treatment decisions. Lithium is considered a mainstay, but ultimately medication choices need to be individualized, in consultation with psychiatry. It's not a one-size-fits-all situation.
So the ED's role is more about stabilizing and ensuring a safe disposition. Speaking of disposition, what happens after a patient leaves the ED? We don't just send them on their way and hope for the best, do we?
Absolutely not. We need to make sure they're safe and have a good plan for follow-up care. A thorough suicide risk assessment is essential for all patients with bipolar disorder, no exceptions.
And if there are concerns about their safety?
If there's any concern at all about their safety, then a psychiatric hold is the way to go. This allows for a more complete evaluation by the psychiatric team and ensures the patient's well-being.
Okay, so it's not just about whether they're suicidal at that moment, right? What other things might make us consider hospitalization for these patients?
Yeah, so the severity of their symptoms is definitely a big factor. Someone experiencing severe mania with a lot of impulsivity, they could be at risk of hurting themselves or getting into some legal trouble.
Right.
And while arrests are more common in this population, so hospitalization might be necessary to protect them from those consequences.
That's a really good point.
Yeah.
We need to be thinking about both the immediate risks and the potential for problems down the road. Right, I think we've laid a good foundation here. Let's take a moment to recap some of the key points for everyone listening, especially for those of you working in the ED.
Sounds good. Let's do it.
First and foremost, bipolar disorder isn't just about mood swings. It's a complex condition with big impacts on both mental and physical health.
Yeah.
And we can't overstate those physical health impacts.
Absolutely. That reduced life expectancy it's a sobering reminder that we need to consider the whole person, address both the immediate psychiatric needs and those long-term implications.
Exactly. It's a whole person approach.
Yeah.
And when we're managing these patients in the ED, it's really about those three key steps: medical clearance, careful medication choices, and a thoughtful disposition plan that prioritizes patient safety above all else.
Couldn't have said it better myself. And with those medications, especially when it comes to the long-term management, we have to remember that the evidence isn't always clear-cut. It's so important to personalize those care decisions and work closely with our colleagues in psychiatry.
Great points. Now, this is something I've been wondering about. With that, shockingly reduced life expectancy, how can we as healthcare providers advocate for better long-term care and support systems for these patients?
That's a huge question, and honestly, one that deserves way more attention. We have to think beyond just stabilizing them in the ED. We need to figure out how we can contribute to better outcomes in the long run.
Totally agree. We can't just be happy with patching them up and sending them back into a system that might not be equipped to support them long term.
Now let's get into those specific medications that Wolf and McCoyne lay out in their article.
Okay, yeah, the medications. That's where it can get really tricky, right?
It can. but they actually provide this really helpful table that breaks down all the different options, like, from the medication class to how you give it, and even special things to keep in mind for each one.
Oh, that's awesome. Like a cheat sheet for bipolar meds.
Exactly.
Perfect, because I know that can be a lot to keep track of, even for experienced clinicians.
Absolutely. And for everyone listening, don't worry, we'll link to the full article in the show notes so you can check out that table in all its glory.
Yes, please do. Okay, but let's go over some of the highlights. Give everyone a taste of what's in there. Shall we start with the typical antipsychotics?
Sure, let's do that.
Okay. So I think most of us are pretty familiar with haloperidol. Halidol is kind of the classic go-to for acute mania and agitation, isn't it?
It is, and you can give it orally, IM, or even IV, depending on the situation.
Right, lots of options there.
Yeah.
But with haloperidol, we got to be careful about those extrapyramidal side effects, right?
Mm-hmm.
And QTC prolongation.
Exactly. And don't forget, it can lower the seizure threshold.
Oh, right.
And there's always that rare but serious risk of neuroleptic malignant syndrome.
Okay, so definitely not a medication to take lightly. We need to be monitoring those patients super closely.
Absolutely. Another typical antipsychotic that's worth mentioning is chlorpromazine, Thorazine. But this one is more for maintenance therapy, usually given orally, and it carries similar risks to haloperidol.
Got it. So similar risks to haloperidol, but anything else to watch out for specifically with Thorazine?
Yeah, you can also see anticholinergic effects and potentially a granulocytosis. It's a big drop in white blood cells.
Yikes. Okay. So let's move on to the atypical antipsychotics then. What's the main difference there?
Well, they often have a different side effect profile, and some may work better for specific symptoms.
Okay, so different side effects, potentially more targeted for certain symptoms. Can you give us some examples of those atypicals?
Yeah, so olanzapine, Zyprexa is a common one.
The Prexa, okay.
That's used for acute mania, agitation, and even maintenance therapy. And it comes in oral and IM forms. You can even get a disintegrating tablet. That can be pretty handy sometimes.
Right. So lots of ways to give it. Any side effects we should be aware of?
With olanzapine, the big ones are weight gain, metabolic issues, and sedation.
Okay, so we got to be keeping an eye on their weight and metabolic stuff. What about risperidol? That one seems to come up a lot too.
Yeah, risperidone, Risperdal. It's used pretty similarly to olanzapine. You've got oral forms, a disintegrating tablet, oral solution. There's even an IM depot formulation for maintenance.
Wow, so many options.
But the main thing to watch out for with risperidone is hyperprolactinemia.
Ah, yes.
Yeah.
Hyperprolactinemia, which can cause all sorts of hormonal problems.
Exactly.
Okay, so definitely something to be aware of. Any other atypicals that we should have on our radar?
Yeah, we've got ziprasidone, Geodon.
Okay.
Another good option for acute mania, agitation, and maintenance. It comes in oral and IM forms.
Great. And side effects.
The main concern with this one is QTC prolongation, so we need to be checking those EKGs.
Right. EKG monitoring is key. And then there's Seroquel, right?
Yes, quetiapine, Seroquel. That's widely used for acute mania, acute depression, and maintenance, mostly given orally. And the most common side effects are sleepiness and high triglycerides.
Sleepiness and high triglycerides with Seroquel.
Got it. Okay, so we've covered a bunch of antipsychotics, both the typicals and the atypicals. What about those mood stabilizers?
Right, mood stabilizers, another really important part of managing bipolar disorder. Let's start with carbamazepine, Tegretol.
Tegretol, okay, so that's used for both acute mania and acute depression, right?
That's right, usually given orally, but it comes with a whole host of potential side effects.
Yeah, I was going to say, carbamazepine, doesn't that have a pretty intense side effect profile?
It does. We're talking granulocytosis, aplastic anemia, cardiac toxicity, liver toxicity, SIADH, Kuhn rashes, including Stevens-Johnson syndrome, and toxic epidermal necrolysis. Wow, you weren't kidding. That's a lot. And it really highlights why close monitoring and patient education are so important with carbamazepine.
For sure. We don't want to scare anyone, but it's important to be aware of the risks so we can manage them properly.
Absolutely. Okay, so what about Dipacote?
Divalproex sodium, Depakote, that's primarily used for acute mania, also given orally. And just like carbamazepine, it has its own set of potential side effects.
Let me guess. Also, a pretty long list.
You bet. So you can see things like low platelets, liver problems, pancreatitis, hyperammonemia, encephalopathy. And yep, you guessed it, those scary skin reactions like Stevens-Johnson syndrome and toxic epidermal necrolysis.
Okay, so Depakote, another powerful medication that needs to be used with caution.
Definitely.
And then there's Lamictal, right?
Yes, lamotrigine, Lamictal, that one's typically used for acute depression and maintenance therapy in bipolar disorder.
Okay, so more for the depression side of things.
Right. It's given orally and generally pretty well tolerated, but you still have that risk of those serious skin reactions. We need to be on the lookout for any signs of a rash and make sure patients know to seek immediate medical attention if they notice anything concerning.
Right, rashes, always a red flag. And last, but definitely not least, we have to talk about lithium, the good old classic mood stabilizer.
Lithium lithobid. It's really considered the mainstay for both acute mania and maintenance therapy, taken orally. But remember, it's got that narrow therapeutic window.
Right, that narrow therapeutic window. So we're always walking that tightrope between effectiveness and toxicity.
Exactly. We've got to be on the lookout for signs of toxicity, which can range from, mild things like lethargy and slurred speech to more serious issues like confusion, ataxia, seizures, and even coma.
Wow, okay. And we can't forget about the potential long-term effects on the heart, the thyroid, the kidneys. Sounds like managing bipolar disorder pharmacologically is a constant balancing act.
That's a great way to put it. We're always balancing those potential benefits against the risks, trying to keep those medication levels right where they need to be. And of course, we're doing all of this in collaboration with our patients and our colleagues in psychiatry.
Right, because there's no one-size-fits-all approach.
Yep.
Every patient is different, and their treatment plan needs to be tailored to them specifically.
Exactly. And that's where resources like that medication table that Wolf and McCoyne provide are so helpful. They give us the information we need to make those informed decisions. So if you want to dive deeper into those specific medication characteristics and recommendations, definitely check out the full article.
Yes, definitely check that out. Okay, so before we wrap up this part, I think we need to talk about the big elephant in the room. Disposition.
Oh, yeah. Good point.
We've talked about stabilizing these patients, managing those acute symptoms. But what about their care after they leave the ED?
You're absolutely right. That's a crucial part of the whole picture. And to be honest, it can sometimes get lost in the chaos of the ED.
Okay, so let's talk about it. What are the key things we need to think about to create a safe and effective disposition plan for someone with bipolar disorder?
The very first thing is to assess their suicide risk. Remember, this population is at a much higher risk than the general population.
Right. And what if we're concerned about their safety?
If there's any concern at all, then a psychiatric hold is definitely the way to go. That allows for a more thorough evaluation by the psych team and keeps the patient safe.
Okay, that makes sense. But what if they're not suicidal right at that moment? Can we just send them home?
Not necessarily. We need to look at the whole picture. How severe are their symptoms? What kind of support do they have at home? Do they have access to follow-up care? Are they a risk to themselves or others in any way?
Okay, so lots of factors to consider.
Yeah, lots. For example, someone who's experiencing severe mania with a lot of impulsivity, they might need a higher level of care, even if they're not saying they want to hurt themselves.
Right, because their impulsivity could lead to risky behaviors or getting into trouble with the law.
Exactly. We've got to think about those downstream consequences too.
So disposition planning is more than just deciding whether to admit someone or not.
It is. It's about connecting them with the resources they need and making sure there's a smooth transition back into the community.
Right, it's about providing continuity of care and setting them up for success.
Exactly.
And that's where our amazing social workers and case managers and mental health professionals come in.
Yeah. They're so crucial. They coordinate those follow-up appointments, connect patients with support groups, make sure they have access to all the resources they need. It really takes a team.
It does. Okay, I think we've covered a lot of ground here, and this has been a really valuable discussion.
I agree. And remember, this is really just a glimpse into the complexities of managing bipolar disorder in the ED. There's always more to learn.
Right, always more to learn. For those of you who want to dig deeper, definitely check out that full article by Wolf and McCoyne. It's a fantastic resource.
It is. So as we wrap up this part, let's take a moment to think about some of the key takeaways.
Okay, yeah, good idea.
The first one being, bipolar disorder is a complex condition that affects both mental and physical health. And that, that tragically shortened lifespan it's a serious reminder that we need to be thinking holistically, addressing both those immediate psychiatric needs and those long-term implications.
Right. We can't just focus on the here and now. We have to be thinking about the long-term effects.
Exactly.
And managing these patients in the ED It requires a balance of knowledge, skill, and compassion. We have to know the diagnostic criteria, recognize the different ways can present, do those thorough medical clearances, and make informed decisions about medications and disposition.
And we need to do all of that while being empathetic and supportive. You know, these patients are often going through a really tough time.
Absolutely. As we wrap up this episode, I want to leave everyone with a call to action. Let's not just be satisfied with managing these patients when they come into the ED.
Right.
Let's take it a step further and advocate for better long-term care and support systems for people with bipolar disorder.
Yeah, we need to use our voices, our expertise, to push for better policies, programs, and resources. Things that will truly help these patients manage their condition and live full lives. It's about thinking beyond the immediate crisis and focusing on those long-term needs.
Exactly. We can all play a role in making things better for people with bipolar disorder. And remember, knowledge is power. The more we learn about this complex condition, the better we'll be able to provide compassionate and effective care.
Don't forget to check out the disclaimer and a full bibliography of the sources we used for this episode. You can find it all in the description.
And if you found this discussion helpful, please share with your colleagues and leave us a review if you have a minute. It helps us reach more healthcare providers and keep these conversations going.
Thanks for joining us.
And until next time, stay curious, stay informed, and stay compassionate.